So hello, everyone. Thanks for joining our second community event. So this time it will be again about the research project. So again, that's the point of this event, is to kind of have you, our members, to present on the research project that they've been doing to a greater audience. And today we're going to hear something about something completely different. So last time it was about kind of flooding analysis. And today we're going to be hearing about Lofty John's project, which is discussing biosecurity and pandemic prevention with a specific emphasis on African nations and the global south. And what he will be particularly focusing on is the role that indoor quality has to play in this. Okay, Lofty John, your space.
Yeah, okay, cool. Thank you, Dr. Barr, for introducing me to the audience. I'm Lofty John, and today I will be presenting on indoor air quality, but in the sense of how it helps in pandemic preparedness, with a special focus in African countries, as Dr. Barr has said. So I guess we'll begin now. So generally, indoor air quality, as the name implies, it's talking about the general ambient air in our surroundings. That's around offices, household spaces, and public indoor spaces, places where a large group or small group of people congregate. So that we could look at it in the sense of the air we breathe in. Yes, and research, strong research has shown that IAQ is strongly tied to our health, as in the level of quality, the level of air we breathe in on a daily basis is tied to how much health we enjoy from the moment of our birth to our death. And usually these IAQ standards affect people and also impart their health in many places. So I picked up IAQ because I noticed that in global south, air quality isn't something that's really focused on. Just like clean water is something we're still advocating for. Clean air is still something that many people still struggle for. And so what are the problems? You find out that when IAQ levels are low, we could have there's a strong evidence that shows that IAQ levels are tied with cognitive development. For children between 0 and 7 years, you find out that as they endure poor air quality, a research showed that their scores on IQ tests were lower than their mates that enjoyed better air quality. And obviously, and very blatantly, it is obvious that poor IAQ obviously affects the cardiovascular system, the respiratory tract. That is, they are more prone to heart diseases, strokes, and ischemic heart attacks, and also respiratory diseases such as lung cancer and lower respiratory tract infection. A research carried out by a group showed that children, usually those between the early ages of development and those that are entering adolescence, had higher rates of tuberculosis and lower tract infections than their mates that enjoyed cleaner quality air. So by the numbers, you could tell that IAQ doesn't just have toll on the health. It also comes with its own economic burden. Across Africa, it was found out that poor IAQ levels led to a loss in GDP of about 6.5%, and for death in the region, about 1.2 million Africans were suffered from poor air quality related deaths, and that's the second leading cause of death following malnutrition in the region. In health systems, we usually measure the burden of a disease based on the disability adjusted life years. That's a metric that shows us how many years in better health would have been lived if that disease wasn't culpable. And it was shown that around 104 million days were lost from air quality related illnesses. That means that if people had lived in better adjusted lifestyles, they could have earned something around 104 million more years in good health. Now, looking at the problems of IAQ, I noticed that in the region, IAQ isn't very strongly held in high esteem by governments or by state actors. And so I looked into the problem, and I'm doing literature reviews and a bit of research on my own. I looked into what possible interventions could be done to improve the air quality that people enjoy in this region. So I looked at what has been done and what could be done. Currently, as I mentioned before, IAQ isn't something that is really held strongly in the region. Interventions have targeted reducing pollution from burning of solid fuels. That's giving household people clean cooking stoves so that the PM 2.5 concentrations PM 2.5 are particulate matters that are less than 2.5 micrometers in size. And research has shown that the PM2.5 levels, higher PM2.5 levels, are responsible for the health diseases. So you can tie down, you can measure the IAQ, the air quality people endure in a place, based on their PM2.5 concentrations. So because of this, most interventions are focused on reducing the use of biomass as a source of cooking fuels, because in most African regions, it's done by combustion of wood, firewood from the villages, or in much more in suburban regions, you would find out that people use cooking fuels, cheaper cooking fuels, that rather than using wood. And you also have the high level of vehicular pollution, because there isn't a vehicle there isn't much legislation controlling the quality of vehicles that can be ridden on the road. So we found that there are high levels of vehicular pollution from the fact that different kinds of cars and engines run on the road. And besides that, you'd find out that across the African region, very few places have any legislation on IAQ. That's among the 54 African states, are there only 17 of them that have any legislation concerning indoor air quality. And among the 5 big economies, Nairobi in Kenya, Lagos, Nigeria, Johannesburg, South Africa, and the two, Tanzania and one more region in Southern African region, you find out that only 2 out of the 5 listed above would have any strong legislation concerning air quality at all. In fact, Lagos, Nigeria actually has no legislation whatsoever concerning air quality. And this shows to us how severe the problem is in the region. On a global scale, comparing the problem to the global scale, you find that in developed economies, for every 370,000 people, there is an air quality monitor. That is, there are systems that are put in place to recognize changes in PM2.5 levels or ozone levels in the air. But in the African region, only one for every 28 million people. There's only one air quality monitor for every 28 million people. That is almost very different in about 20 times worse than the global average. And you find out that the trend in the region has been showing that IAQ levels have been falling. For instance, in Nigeria, in Western African region, among the all West African states, you find out that particulate matter pollution has risen by almost 9%, with Nigeria being hit the worst at around 12%. So I looked at the interventions that have been done concerning the fact that IAQ levels are poor in the region, and that the trend shows that things are getting worse and things are not getting better. But you have to look at what has been done to understand what could be done. And I found out that most research has been behavioral, or looking into giving people better cooking stoves, that is giving people clean cooking fuels, putting legislation in place, and also trying to carry out mass education. But from the trend, it shows that such interventions haven't been very helpful, or they haven't been implemented very well. So looking at these different interventions based on policy, behavioral, and non-policy, I decided to focus on engineering interventions that look at the HVAC industry, that is the heating, ventilation, and air conditioning industry in this region, and how we could improve HVAC standards in this region, and see how that could translate to higher indoor air quality. And so I proposed my work proposed 3 main mechanisms: air filtration, ventilation, and air disinfection. The first 2, air filtration and ventilation, are mechanical interventions. That is, would require the movement of air by artificial means in the room, rather than relying on natural ventilation. And we use them. And the last, disinfection, uses machines to produce UV rays that will kill microbes moving around in the air. And so these UV rays are the major point of this intervention is to reduce the level of flu-like microbes that move around the air, to reduce the spread of influenza-like diseases. And so while we improve the quality of air by reducing PM2.5 concentrations, we can also improve it by reducing the amount of microbes that are in the air, therefore reducing the disease burden that people suffer. Now, research shows that there's a metric we use to measure how effective each intervention is, and it's called the air change per hour. The air change per hour for each intervention varies, with filtration being the lowest and the use of disinfection at the highest. And research shows that each air change actually translates to about a 60% reduction rate in pathogens. That means if you had around 100 in a room of a meter, in every meter square, if you had around 100 pathogens, but after an hour of using each intervention, we could hope to have only around 40 pathogens, which is actually, which on impact in microbe spread modeling would actually show a greater decrease in the spread of influenza like diseases. So in this here I explain the basic interventions, looking at them in each category. Air filtration. In air filtration, as I already mentioned, it's a mechanical intervention, and the most promising use of air filtration is when we look at the use of high efficiency particulate air filters, that's HEPA filters. There are HEPA filters which have been shown to remove about 99% of particles in the air, therefore reducing exposure to PM 2.5 concentrations and hazardous gases. Air filtration normally is done using an air filtration system with air filters. Most air filters these days have been made to remove particulate concentrations below PM 2.5 levels, because they use nanofilters, and these nanofilters work by taking in the air in the environment and try to give out cleaner air. The idea, but the major pitfall with air filtration is that we cannot target all pathogen, or we cannot target pathogens or certain pollutants like fine dust, which is very much in the region of sub-Saharan Africa because of our closeness to the Sahara Desert. You find out that PM 2.5 levels are higher in the region, especially during the dry seasons, where the trade winds bring in dust from the Sahara Desert. So air filtration really helps in reducing levels of fine particulate matter. Or during this seasonal changes, you find out that air filtration technology may not be able to work as efficiently as. So we usually combine air filtration with ventilation using artificial ventilation systems, whereby we can change the air, and whereby buildings are designed to ensure that the air is changed, the airflow it's constant, and the air is changed in around every 5 to 6 hours, therefore ensuring that air filtration technology works at its highest, especially in the region of sub-Saharan Africa, as I mentioned, where due to the seasonal changes and the increase in fine particulate matter. Another promising intervention is the use of germicidal UV. Germicidal UV has been used before in developed economies. In developed economies, mainly in hospitals. There are two main pathways to use the use of germicidal UV. We have the upper room UV systems, where UV bulbs are put up as set up in a room, and only air of the upper strata is disinfected. Therefore, the air we breathe at room level isn't disinfected. But there's also the use of far UVC. Far UVC is actually promising. It's still a fledgling technology. We haven't seen mass scale use of far UVC. Research is still going on in far UVC. Far UVC is actually a more promising intervention, as we could install far UVC systems in our homes and around places we stay in, as in like on ground level, because far UVC makes use of the threshold of far UVC. The frequency far UVC makes use of is actually not lethal to the human. From research, isn't lethal to human cells and doesn't cause cancer, like in the case of upper room disinfection systems. Upper room disinfection system, we make use of 254 wavelength of around 254 nanometers, and as we know, these are high energy waves, and the high energy waves on impact with cells usually destroy cell organelles and can also lead to cancer, as we are aware. But with the use of far UVC, we don't need to bother about the use of such wavelengths anymore. Lower wavelengths of around 220 nanometers, 228 are employed. In far UVC, we use different waves. Different waves or thresholds are employed, therefore making a more promising intervention in our household, to the fact that we could install these systems around, and therefore the air that we breathe in around us is actually disinfected rather than just the air of the outer strata. And so far UVC holds a lot more promise for human use, for large scale use, rather than upper room UV systems. One study showed that germicidal UV genocidal UV disinfection actually with far UVC showed around a 90% reduction in coronaviruses in under 8 minutes, and in 25 minutes, around 99% of all pathogens were removed from the air. But there still remain ethical uncertainties around far UVC. We have uncertainties about if people would consent to using a UVC system in public spaces. Could we take the use of ultraviolet disinfection as the same as vaccination? In the sense that in vaccines, you are asked for consent before you are given a vaccine. But in sense of germicidal UV, can we use germicidal UV disinfection systems without people, like, will people consent to the use of UV systems in public spaces? What is the general consensus on the use of UV systems? And so my proposition, looking at the different interventions to improve IAQ in the sub-Saharan, in the African region, was mainly this. It looked use of data gathering, in the sense that youth-led campaigns would help us to gather data based on IAQ levels to monitor if the interventions are successful and what types of interventions are needed based on places. And a data analysis phase will be carried out to understand how this data would tell us what interventions to use and how it relates to the cultural context of the places. Because when carrying out any intervention to remedy any problems, you have to understand the cultural context of the people, especially in regions where culture is held in high esteem. And so a pilot intervention of around 6 months will be required to understand how these interventions play out in the region, because uncertainties still remain about research in the lab tells us, yes, these interventions are successful, but uncertainties remain about how successful they will be on the field. We usually have cases where when we deploy a solution to the field, we have less success rates or yield rates than what we expected in the lab. And so the major deployment strategy is to use upper room UV and far UVC systems in hospitals and clean cook stoves in houses to reduce PM 2.5 concentrations. We're focusing on the use of far UVC and upper room UV in hospitals to reduce pathogen spread rates and reduce the occurrences of influenza-like diseases in these hospitals. And also a major step towards deployment will be to target partnerships between these public offices and hospitals. And after that, in pilot program, we carry out an intervention an evaluation to understand how successful the project was. But there still exist certain risks concerning the deployment of IAQ intervention solutions to reduce the level of risk of pandemics African nations face. The major problems fall into three main categories. One, cost effectiveness. Looking at the region, we understand that looking at the context of the regions, the reason why these interventions were successful in developed economies was that they had capital, the human capital, number one, and the assets, the financial capital to carry out these interventions. But in these regions, we find governments still battling with basic things like water sanitation, providing healthcare for the populace, and free education and education as a whole. And so we find out that looking at interventions as such to improve biosecurity in the region may not be taken very strongly by government actors. So we have to create a strong case for why these interventions should be considered. And so, and looking at the cost of the machines and the cost of training people in the HVAC industry to deploy these machines compared to the benefits, doing a cost benefit calculation, we find out that compared to other cost areas, compared to other problems that these nations could work on, improving biosecurity in terms of IAQ isn't too promising. But in the long run of looking at the growth rate of the population and looking at the economic growth rate, we find out that in certain regions such as northern African countries and southern African countries, in the next 5 to 10 years to come, you find that the cost effectiveness concern starts to lower, and you find that this the cost benefit ratio starts to improve. So governments can actually take these interventions as successful interventions to improve IAQ in their region. And there's also the problem of the knowledge base and the skills. As I mentioned before, in the cost effectiveness, the HVAC industry in African nations isn't especially in sub-Saharan Africa, isn't developed. It's a fledgling industry. You rarely find degrees in the level of technical expertise isn't there yet. So you would still, there's that concern of how would we be able to ensure maintenance of these interventions. Air filtration technology and ventilation technology is quite expensive to install, and so maintenance would be a very strong key point when looking at installing these interventions. And so we have the problem of the knowledge base and the skills that will be required to deploy this technology. And also there's the policy and the public. There's still policy, as I mentioned earlier, there's still ethical concerns about the use of fire UVC and UV disinfection technology as a whole. There's strong skepticism as to how people would respond, especially in their cultural context. How would people respond to breathing in air that has been disinfected by UV rays? The general idea is that UV rays result in cancer, and so how could you, or in genetic mutations? So how could you change this general outlook of the whole problem? How could you convince the public into accepting this new technology? And that is a really big problem in the developed context. It might be possible through mass information and education, but in the developing nations context, as in sub-Saharan Africa, not many people are educated or have access to access to media that could help reduce the level of misinformation and disinformation that could be passed. So how do we educate people about these things? What methods, based on the cultural context of African nature, could we employ to ensure that people understand that UV disinfection isn't all that bad as they understand it? And how do we influence policymakers or stakeholders to take these interventions as serious? And so these are the major pitfalls of the of improving IAQ in Africa. These are the major challenges that one would encounter while trying to improve IAQ in sense of improving our pandemic preparedness in the African nation. So while I carried out my analysis, while I carried out my research, I didn't just do a literature review. I thought it would be nice to also carry out an analysis from the economics perspective to understand the arguments for these interventions, like how promising are these interventions as a whole. Literature review, existing research tells us, yes, these interventions are good. Scientific community relies strongly on improving air quality in homes as a good way to improve our health. But while we look at the benefits, as I mentioned before, we also have to look at the cost. In the African context, there's a certain level where certain things become too expensive to do, and government only has limited funding. And so you have to look at it from the economics perspective. When you're making an argument for an intervention to be carried out, you have to look at the cost of carrying out that intervention. And so I did a crude analysis based on a model, on an open source model, on a model that is available for the public. I found on the internet. Maybe later on I could share the model. And the model takes into account 4 major things: PM 2.5 level concentrations, and the attendant loss of life years. As in, higher PM 2.5 level concentrations means that life expectancy will be lower, and that means that there will be and that means people living in these regions will have a higher chance of dying younger. And also the electricity cost, the cost of installing these systems, because these systems work with electricity, and in these regions you have to consider the cost of this too. So looking at the analysis for all 54 African nations, there were 4 countries I picked out. I noticed that were promising. I define a country as promising when the cost of gaining an extra year of in good life is below $300. And I define this as and I define an intervention as possible when it is below $250. So during my analysis, I found 4 major countries: Burundi, Nigeria, Cameroon, and the Central African Republic. All regions have the cost of producing an extra year of added life by installing IAQ measures at under $300, with Cameroon being the lowest at $212, and the Central African Republic being the highest at $299. And so you'd find out that the cost per life year gained for installing these systems is actually, in developed country context, would actually be really cost effective. And when you take into the account that these systems are shared by a general public, you find out that you have like a multiplying effect. For each person for each system you install, you expect to save an extra year with $221. But if that system is shared by a family of 5, that cost is reduced by 1/5, is 1/5 of its original value. So if producing an extra year of life costs $221, then for 5 people using that system per person, the cost would be around 44 point around 44 around $44, $45, which would be actually cheaper in the developing economy context. So you find out that cost effectiveness, in terms of cost effectiveness, these 4 countries are really promising. And so while we look at the problems that improving IAQ could solve, and the problems in itself of improving IAQ, and also why we should improve IAQ, and looking at the economics of it, we also have to look at how could we sustain progress in the region? How could we sustain progress in improving the pandemic preparedness of this region? That's the pandemic resilience of the region of African nations. What markers do we use to know if we're making progress, and how can this progress be sustained? So in the near term, IQ interventions should focus on 3 major cities in the focus countries. That is, looking at the 4 major countries where the interventions seem to be cost effective. A first pilot program, as I mentioned before, of around 6 months will be necessary to understand how successful these interventions would be based on their cost effectiveness. And so you find out that when a near-term intervention is carried out, IAQ is deployed in public spaces, that is in government offices, in hospitals and schools. We could also, if the results are positive, then we could implement them in private places too, and also call for private partnerships and investments. And also we could also in the near term too, because of the problem of the understaffed HVAC industry, or the weak HVAC industry in Africa as a whole, in the near term we could also look at training programs to improve the level of expertise we have in this industry. But in the long term, as I mentioned, we find out that cost effectiveness improves over a scale of 5 to 10 years, 10 to 25 years. And so in the long term, you find out that bringing down IAQ interventions to reduce pandemic risk in the region is actually more cost effective. And you would find, and because of this region, we should expect that there should be a national installation of pandemic preparedness measures, and you'd find out that there should be a 50% in reduction in PM 2.5 level concentrations if these interventions are successful. And research and development should be carried out in this region to see how far UVC could be developed in the African context, and we'll also see a large decrease in deaths related to air pollution incidences as IAQ levels are improved in the long term. And we'll also see a decrease in deaths due to air pollution, and also a stronger and healthier nation that will be ready for a pandemic in case one occurs. And so charting out a possible plan of how these interventions could be deployed, I noticed potential partners and what policies lawmakers could make. Potential partners exist in the HVAC industry, that is in the still growing HVAC industry of African nations, in air quality focused non-profits such as the Clean Air for Africa, the Clean Air for Africa Coalition, the hospitals and healthcare providers. These are major actors that could be focused on when trying to deploy IAQ related interventions. And international aid groups such as the USAID and the UN and WHO, different groups that work in improving health in developing nations. And so we'd also look at the IAQ related policies that could be made by lawmakers in this region. We could have community advisory boards to ensure that that communities carry out these interventions duly, that these interventions are effective. We could also have the training and the licensing of people to ensure that to grow the HVAC industry. That is, lawmakers could pass a new legislation that allows licenses to be obtained at cheaper rates and the years of study to be lower, so that we have more people in the industry and to ensure the deployment of these interventions. We could also have private actors coming in to carry out their own IAQ interventions rather than relying only on government-sponsored or government-funded projects. We could also have private partnerships. That's private people working with in liaison with the governments to carry out their own interventions and to see how effective they could be. And we could also, and there's also a potential fault of waste, as in the sense of electronic waste. A lot of waste could come from the production processes of these devices. So legislation could be put in place to prevent this by ensuring that waste is responsibly recycled and filters after they are used are responsibly disposed of to prevent environmental risks. And so my parting thoughts on improving IAQ in the region from the economic perspective, and also looking at what interventions could be promising in the region over the short time frame of a year or two and a long time frame of around 5 to 10 years, you find my concluding thoughts are that IAQ as a whole has been heavily overlooked from my research. From what I've looked at, IAQ as a whole has been heavily overlooked, especially in sub-Saharan region. And by implementing interventions, as I have mentioned before in my talk, you'll find out that we would have reduced level of PM 2.5 concentrations and resulting in improved health for the people. My dream and the dream of my project is to improve resilience in the region and to ensure that the progress is continuous and ensure that all actors are held responsible in improving the air quality that the region enjoys. And by working together as a group, we'll find out that improving indoor air quality in Africa will result in better health for the people and healthier and wealthier nation. Yes. So in general, I hope you enjoyed my talk, and I'll be glad to take any questions if you have any. Thank you for listening.
Okay, thank you very much. So question time. Do you have any questions that you would like to ask? And always remember to unmute yourself. Right, since there's no one asking, I'm going to be asking some questions. So I'm not sure I was able to follow your effective cost analysis like properly, but I found it quite disturbing to put like a price on like a 1 year of a human life. All right.
Yeah.
I mean, in general, there should be, I mean, of course, this is in a sense idealistic, but that's what we should be striving for, right? Is to improve the lives of people. It's not about kind of whether we're going to be making money with that or someone's going to be making money with that, that people can live one life a year longer. So using people as a resource, so I find that highly disturbing. So how did you kind of decide, like, yeah, so what are your thoughts on that? Maybe let me ask this way.
Oh, okay. Actually, I also find the thoughts disturbing, like the fact of valuing putting a price tag on a human life. There isn't actually any level of finances that one could offer for you can't buy a human life, you can create one. As far as science is concerned, we haven't reached that level of research yet. And so, but when it comes to talking about economics and development economics and welfare economics, especially in regions that are resource constrained, we have a project. There's a project right now. I'm just giving a scenario of why we have to decide to do that. There's a project right now. Imagine there's a funding by foreign investors in a country of around $10 million. And so okay, we could actually spread out the funding on 4 different cause areas. Let's say we could look at providing mosquito nets, ensuring that people don't have malaria anymore. That's one thing. Building schools so that we have a generation of leaders. That's another thing. Right. Then we have providing clean water in villages. That's another thing. Then the last one, let's say lead poisoning. Creating awareness to reduce lead pollution levels in these economies. Those are 4 different cause areas, 4 different problems that one society faces, and they have $10 million to solve all 4 problems. And so, but we know that each problem can't save the same amount of lives. Probably if I put $10 million into buying mosquito nets, I could save around 1 million people. If I build new schools, okay, we don't save lives through education. Let's say the value of building new schools is around educating 500,000 children. And then we also have the lead pollution levels. Investing in lead pollution, investing to reduce lead pollution levels could save around 5 million people. And then you have what was the last one I mentioned? Clean water. You have providing clean water could provide around 20 villages with new water, which have an inhabitants of around 2,000 people. So you are down to that 1 million number again. And so we could save, in each case, we could save people, yes. But there's only one intervention that could save the most people with the limited funds we have. And so like that's why we have to boil it down to the numbers. Numbers is actually quite detached. Is I don't say it's inhuman, but it's what has to be done to ensure that we save the most people. It's limited funds, and so with those limited funds, we have to find the best ways we can to help people. The best interventions are what we have to invest in as a government. I'm just looking at it from the development economic side. So that's how like those decisions are made from what I understand. But like while doing the effectiveness, and it was actually quite disturbing because if we could actually save more, if we could save people, why don't we just do it if we can? That's what I thought too. But like that's not really the reality in most regions actually.
Okay, so I understand that. Again, there are many things that need to be done, and you kind of need to advocate why to kind of attribute funding to this particular topic to improve indoor air quality. But I mean, then. Okay, and I guess just for me to understand, so you have the problem that since you kind of don't save lives, kind of like directly, or it's harder to figure out with indoor air quality, because I guess like for the studies, the problem is also to isolate it from other effects, right? Because there is a kind of like you have also compound effects. Like if your water is not clean, if you have problems with malaria, right, then the indoor quality is not good. Maybe like you malnutrition, so all these kind of things come together. So it's actually very hard to isolate the effect that air quality kind of has on a people's lives, so that you can say, okay, we could be saving so many lives because that's the kind of currency that this is currently compared in. So how is that then determined for indoor air quality? So this is I wanted to ask that about the studies in general, because you mentioned like relationship to IQ, and I kind of can understand that a little bit, but I'm just wondering like how are these studies set up to kind of produce objective information about like how lives are affected, or how many lives could be saved?
That's great. Generally, because as you mentioned, there's like a compounding effect. There are many problems, and it's hard to isolate how solving one problem could improve lives in general. Yes, and so for IAQ generally, usually how to understand how these lives, how it translates to saving lives. We look at the diseases. We look at the diseases that happen. Like, what are the health burdens from this disease? So, like, okay, what is generally done in health economics is this. Like, from what I understand, I'm not a health economist, but what I understand is like, so a survey is done like to determine like, okay, we asked like a group of 100 people, what do you rate your life? At what level would you rate your life if you had tuberculosis? And so like from a scale of 0 to 1, so you can put 0.4, 0.5, 0.6, things like that, or like 1 to 10, but something that's like out of a percentage scale. And so like if you are on average, you have like, okay, I rate the quality of my life at like 0.5. So that means that people would rather, so that means a year with tuberculosis is almost equivalent to 0.5 years of a 0.5 of I'm modeling my thoughts. A year with tuberculosis, it's almost equivalent to 0.5 years with 0.5 years with in normal health, as in you would trade a year with tuberculosis to get half a year of normal health. And like the higher it goes, the more pressing the problem is. As in if you would trade half a year of tuberculosis for half a year, like if you trade half a year of tuberculosis for half a year of normal life, that means that the problem is actually the scale of the problem is higher. And so like we rate the burden to understand how improving IAQ could translate to better health. we rate it based on the disease burdens, like how people in general would value their lives if they had these diseases, like a counterfactual, like if you had this disease, how would you value it? What would you value your life as? And so those kind of things. And so we add up those effects. And I don't know. There's obviously there will be data, and there will be skewed. There will be the data will be skewed. Not everyone would come at a certain mean. And so like when the data is analyzed, okay, we tell you that okay, so everybody it actually costs so everyone it actually costs like people would actually rather live 2 years with tuberculosis than live a year in good health, something like that. And so like then there's like a metrics on what we value a year of life as, a year of life in good health as, like there's a numerical metrics, and that numerical metric is often gotten by like you look at the cost, like okay, what is the cost of bringing in like better air filtration systems. Like in what I did, I only looked at electricity costs, and the cost of like maintenance, stuff like that. But in more objective, like in stronger research groups, they'll start to look at the cost from absenteeism at work, the cost of going to hospitals, the cost of reduced economic GDPs and things like that. And so all that is scaled in to now determine like the general cost of poor air quality in general. Oh yeah, there's going to be like abnormalities because we can't entirely segregate IAQ from other things. But like when you start looking at only respiratory disease, you've actually done a lot of work. You've removed out causes like water, maybe malnutrition and things like that. Malnutrition would come out a little bit, but like we know that poor feeding could affect health and things like that. Yeah. So that something like that is done. Look at what happens and like the cost of what happens. Then look at then try to compare those two things to understand what will happen if we improve IAQ.
Yeah. But then are the same metrics then applied to the kind of other interventions? So we say kind of okay, mosquito nets, malnutrition, good clean water. So because like there is, I mean, those metrics are not purely objective, right? I mean, at the end of the day, someone needs to decide like what are the factors that are going to be used here and how is this going to be accounted for. I don't think, I mean, you can correct me if I'm wrong, but I don't think that there is a kind of an objective measure that is going to be applied to that because it's also extremely hard. So you will only focus like on certain things. So then have you kind of done this analysis, or I guess not, but like, or has that analysis been done, or are the same metrics being used like for the other methods, so that you can at least kind of say, okay, there is no bias for one method or the other, kind of how many lives it saves, so that you can actually compare what intervention is most important to do or most urgent?
Okay, yeah. Yeah, if I understand you, like you're looking at like what metrics exist and like how they're used across all interventions, right?
Yeah.
Yeah. Okay. So yes, analysis have been done like in health economics. From what I understand, there are like three major things. There's well-being adjusted life years, disability adjusted life years, and quality adjusted life years. These are the three major metrics that are used in determining like what these interventions do, like how they translate to better health. These are the three major metrics that are used. But like the problem is that yes, bias. Like I noticed like there's a strong consensus against these of disability adjusted life years, that daily DALAY. That's what I used in my own project. Though there's like in the community, it isn't really like you rather use qualities and wallies over dailies, right? When you're trying to value interventions, but like based on data, because of most old work has been done in dailies, it's better to rely on that dailies, because like there's much of the old work has been done. But in recent health economics, you find out that more people are shifting away from using dailies. Like there's like ethical concerns about how risk taking, the bias and things like that. So like yeah, your concerns of bias are not unfounded. They actually exist. And so like with each metric, we try to like reduce those biases, improve them and things like that. Yeah, and like try to make them better. And so like because we have these metrics, like we try to like every single intervention is kind of like valued in the same metric. Like if you're trying to decide if you're going to do mosquito nets or provide multivitamins for children to stop malnutrition, then we look at okay, so if $1 here, okay, $1 to provide mosquito nets will give one better 1 year in health, but $1 to buy multivitamins give 5 years in better health. So like that's how the metric works. So like we can now say okay, $1 here will give one. Let me create my own like metric because I'm not sure how the other metrics are made. Maybe one one Harley, and $1 here will give 5 Harleys. So we rather go with the intervention that gives 5 Harleys, that kind of thing. So like that's how it's done, like based on these metrics is. So the one that creates more higher metrics is for each dollar invested. So that's how those decisions are kind of made. But like, yes, there are biases in data, there are biases in choosing these metrics. So like it's hard to determine what to use.
No, that's fine. I mean, as of course, like any kind of any objectification means that you have to introduce a model and simplification, and especially if you want to assess something complex as that, then this will never be perfect. But the most important thing is that there is kind of not a bias. I don't know what the term for that is, but like that you know, you let me say the positive way, that you use like all the metrics, that there's a set of metrics that is applied to every intervention, so that there can be like an objective, or like, well, as close as objective possible decision that you're applying the same things, but you will never perfectly know. I mean, there is also the problem currently that I also like to stress, that we're overlying on data, that we think like, oh, from data we can kind of figure out everything, and this is just not the case. But anyway, another interesting question would be, so you've been doing that in a team, or you've been doing that alone? Because sometimes you mentioned we, so I was thinking that there might be a team.
Oh yeah. For the first, I did a project over like 6 months, like 6 months ago, and the first time I did this, I did it on my own. Like it was just on my own, working on my own. Then like 2 months ago, like I got like a partner, I got someone else I'm working with it on. So like, yeah, because like what I did was really basic, and I'm trying to like, and person has like experience in academia, so like it's going to be a much refined project. Like I'm going to like even out the things I didn't do properly. So that's why I started saying we, because like in the short term, right, as of now, I'm working with someone on it, like to try to improve it. But this is basically what I have done on my own first. And I'm saying we because like I have another thing. I have the same work. I'm trying to like improve it with someone else. Yeah. So like what's here is basically what I have done before the partnership. So like, yeah, it's a teamwork. I could say it's a teamwork now. Yeah, it's a teamwork. But like this what I've done now is just what I did before the partnership.
Okay, cool. And so are you considering kind of to submit your project like to or suggestions also to local authorities or like NGOs?
Yeah, that's actually like the major crux of the work. We're trying to like do a biosecurity report, because like if you look at developing context, you don't see anything like that. So like if future groups we want to invest money to help people in Africa, what can we do? People are already doing water, people are doing multivitamins, what other cause areas exist? And we're like, okay, hey, see, we have this work here, this and this and this, and you can do this and this and this. So like a guide. So like, yeah, we want to like create, we're like not publish as a paper like yet. It isn't paper level yet. It's like more like a policy proposal, something like that. Yeah, so like that's what we're trying to do, like create a policy proposal and things like that, and like a guide and a report, and like we'll post it on like groups that have like all these social welfare related causes. That's what we're trying to do.
Yeah, that's awesome. I think it's also very important that it kind of comes from you, who are kind of local, and not that it comes like from the top, like from the external. Because I think you mentioned a very important point, and this is the awareness of the local culture and like how people perceive these things. And of course, they need to be convinced that this is a good thing and that this is not a bad thing. And that of course requires some subtlety, and not just basically, well, we just dump this on you and you have to use it, and if you don't use it, we take it away again, and then nothing has been changed. So in terms of the interventions, you've been I try to understand kind of what you think most important, because like one thing that I'm thinking about is of course building like so I understood that you want to focus on public places first, because this is like where many people gather, like schools and hospitals. So I think that is very sensible. And in these places, so then are you thinking of installing kind of high level air quality I don't know how they things called, but intervention. So basically the problem is, if I want something higher level, right, then I also need to really make sure that the building is built airtight, right, so that you have an internal air circulation and that you do not mix in the air from the outside, which is of course quite expensive. And here I don't know like how much you would really need. Or are you thinking of kind of simple interventions first, which maybe cost more electricity, like you have these kind of air cleaners that you can essentially buy for a home, right? I mean, they are not terribly cheap, but I think this is something that you could kind of start putting into rooms, which can deal with both to a certain extent, right? So filtering out dust, I think that is find us. That is one problem that you mentioned, which I think is should be very serious, as you said, due to the closeness to the Sahara Desert. And the other thing is, of course, to deal with microbes, especially then in hospitals and in schools and public places. So if there is someone infected, that you do not have a large spread and everyone gets infected, and then you have a problem. So is it more about installing these kind of higher level things that you were thinking about, like professional air ventilation systems, or are you thinking about these kind of lower level things?
Yeah, it's actually lower level because of like the cost. The cost is it will be like exorbitant. So like it's lower level first. But like when because like there are two sides, there's the near term and long term, as I mentioned before. So like in the near term because you can't like put in all the money at once. So like in the near term, it's actually lower level things for like standalone air filtration systems, as you mentioned, and like small UV disinfection lamps in like hospitals and small indoor spaces, things like that. But like in the long term, I'm trying to look at if it could be scaled out to like so that future like new commercial buildings that are coming up, like you have like the economy of these areas like are growing. Like we have 5 major economies that are growing in the African region, and so like if we could put it in legislation, like in the short term, that okay, buildings have to be built this way, these are the standards. So we have it that future costs wouldn't be as high as if buildings are already built based on these standards. Like that's the plan. So like those professional systems, installing those professional systems would come in newer model buildings. We don't have to start rewiring the buildings we have because there isn't enough funds for that. So we're looking at okay, in the long term, when we start building other buildings, there will be a legislation in place that would ensure that people build buildings based on these standards and they put this and this and this in place, those kind of things. So yeah, but in the short term, it's actually just small standalone air filtration units and things like that.
Okay, no, that makes perfect sense to me because this is kind of easily done. And the problem, as you also mentioned, is that if you have like the high tech thing, that of course that needs to be maintained, and you have to have people like trained to be able to do that. And this is of course a problem. So no, I think that's a great idea. So here we go. We reached our hour. So thank you very much. That was really interesting. I really like this project. I really liked your approach, and I think it's super important. So kind of best of luck with this. Of course, we're happy kind of now that you can give them the talk. We can also advertise that a little bit. I mean, it's not that our reach is kind of massive, but you can help us by if you want us to mention certain organizations, like on LinkedIn or something like that, to kind of just draw awareness to this, then we can of course do that. So just kind of let me know. When the recording is going to be posted, then we can include that in that post to at least help you to get a little bit of a reach and kind of advertising for you, that anyone who's kind of interested in supporting you and in helping you out in this to kind of really make this work, then that they can actually do that. Because again, that's the tricky bit, right? As always, to kind of get people to help you to support it and to make this project a success. Okay, so thank you very much. Very interesting research projects. Lots of success with it, and keep us posted how it's going.
Sure. Thank you very much, Dr. Bar. Thank you for the time to talk. Thank you very much.
Bye-bye.
Yeah, bye.